primary healthcare, there are many dimensions to consider: demographic shifts, changing health system priorities, and community needs. At the same time, many countries are confronted with health workforce shortages, maldistribution, lack of retention, and skill mismatches. Each speaker will try to stimulate discussion by posing one question at the end of their presentation. This question is meant to make us reflect on a specific topic and start a debate amongst yourselves. Please use the chat section of Zoom to share your views on the question. Please make sure you send your answers to everyone and not hosts and panelists. I'll say that again. Please send your answers to everyone. Please also feel free to ask your own questions to the speakers in the chat, which we will do our best to answer in the Q&A session later. We will do all we can to try and theme the questions and get through the questions. So please do that. Put those questions also in the Q&A field of Zoom. We are recording this session, and the recording will be made available with yourselves in the next few days. And I know that in previous seminars, in previous years, not only has there been good take up on the webinar itself, but good numbers looking at it afterwards. So I'm delighted to introduce our speakers, who will then each have 10 minutes to present. I've decided to tell you about each of them at the start in order that there can be a natural flow between speakers rather than keep coming back to me and make it disjointed. And I hope that this will work for you. We have a fabulous lineup of diverse panel, both across characteristics and globally. Our first speaker is Dr. Yoseph Mamo, a medical doctor from Addis Ababa in Ethiopia. He is currently leading THET, that's the Tropical Health Education Trust, leading THET's non-communicable disease centralization project, which is being implemented on 60 primary care facilities widely distributed in Ethiopia. He's been active in giving technical assistance to the Ministry of Health, completing the National Palliative Care Guideline and health providers training for pain management, as well as policy and national strategic framework for non-communicable diseases prevention and control. Our second speaker is Christine Hancock. She is the founder and director of the C3 Collaborating for Health organization and has recently delivered programs in Tanzania, South Africa, and Kenya. Christine was formerly the Chief Executive Officer of both the Royal College of Nursing and Waltham Forest's NHS, and is now on the NHS Health and Wellbeing Advisory Board. Our third speaker is Niclas Forsling. He's a project manager for the Centre of Rural Medicine in Storuman, Sweden. Storuman has become a talent hotspot for companies and researchers focusing on innovative rural healthcare, addressing the demographic challenge of an aging population. Our fourth speaker is Professor Niro Siriwardena. Niro is Professor of Primary and Pre-Hospital Healthcare at the University of Lincoln, England. He's Director of Community and Health Research, a research centre at the University of Lincoln focused on quality improvement and implementation research, including studies on education, training, and the licensing of general practitioners. And our fifth and final speaker is Dr. Katherine Rouleau. She is a family physician at St. Michael's Hospital in Toronto and the Vice Chair of Global Health and Social Accountability in the Department of Family and Community Medicine at the University of Toronto. Her clinical and academic interests include health equity, the role of family medicine, and primary care in strengthening health systems locally and globally. Unfortunately, Catherine's not actually available to join us live today, so she's sent us a recording of herself, but we played at the appropriate time. Without further ado, I will in a moment hand over to our first speaker. After each speaker, I will just ensure continuity and hopefully ensure no anxiety for the speakers by making sure that I thank the previous speaker and hand over to the next, so that we have natural flow, but without too much from me. So, as I said, without further ado, I'm very pleased to welcome and hand over to our first speaker, Dr. Yoseph Mamo. Over to you, Yoseph.
Thank you very much, Simon. I'm going to speak on tackling non-communicable disease in low-income countries, an integrated primary health care approach. Next slide, please. Now, Ethiopia is found in the Horn of Africa and over 100 million people, twice the size of France, and life expectancy is now 65. This has been achieved probably over the last 2 or 3 decades. And non-communicable disease and injuries are now with a magnitude of more than 52% of mortality, which is surpassing maternal child health care, nutritional disorders, and infectious disease. Next. Next slide. Decentralization of non-communicable disease as a strategy of primary health care, we believe achieves the following: universal health coverage for the rural poor, access to non-communicable diseases, care, quality of care, and patient safety. We also believe that it alleviates the burden of care on hospitals and the burnout of very few specialists that we have. Next slide. Primary healthcare approach or a public health approach involves, in our specific situation, task sharing from highly specialized team in the tertiary referral hospital to a primary care middle level health workers and cadres by simplifying and standardizing tasks, by augmenting that with training, mentoring and follow-up of trainees, supportive supervision of facilities, whether they have all the necessary supplies, community engagement and mobilization, which is important for demand creation, health-seeking behavior, early screening, and also continuous collection of evidence, because, you know, does this approach or scheme benefit or does it cause harm? We need to really prove that. Finally, health partnership is very important, both north to south and south to south, for experience sharing, research, and knowledge transfer, as well as a private to public partnership for resource mobilization. Next slide. Let me, just to illustrate what we are doing, I thought better to tell you a story, then what we do becomes, you know, a little bit clear in a shorter time. Let me tell you a story of a young man, a 35-year-old young man, a very important member of the rural community. He's a teacher who gives a chance for rural young boys and girls to go to college. And one day he was working in his garden and he developed a foot injury. He sustained a foot injury. And he went to the health center, and it was very, they cleaned it up, patched it up, gave him the TAT as they usually do, and sent him home. He came back a few days later with worsening situation, with pus, purulent pus coming out, very complicated, and then they added antibiotics, cleaned his wound, and sent him back again. But he came back a third time, a few days later, with even more alarming situation of fever, swollen feet, and very infected wound. And one of the nurses we trained in diabetic care suspected that this could be diabetes, because his wound is not healing as usual. So she checked and it was very high, and she immediately referred him to a referral hospital where he was admitted. And in this hospital, you know, days from probably infection, sepsis was prevented, and probably disability from loss of a limb, amputation of the limb was also prevented. And finally, when the patient was stable, he was evaluated by a nurse practitioner, and he was found to have retinopathy, and which, you know, undetected in 10 years' time, probably at most, this person would have become blind. So a lot of complications, acute and chronic, were prevented here. Next slide, please. So nurses at the primary level can be trained to screen, diagnose, initiate treatment in stable patients, not like this one, but others, modify treatment, recognize when to refer or when they need higher consultation, guide community and health agents in various activities that promotes the care of NCD patients. Next. The role of GPs at the primary hospital is to be trained by the specialists at the higher level, and they can organize their clinics better and also do cascade training. While they are practicing also, they can so train the nurses at the health center level and health officers also, and they can continue to mentor these nurses and health officers. Next. At the hospital level, nurses can be task shifted with operating, retinal cameras to take pictures. Sometimes doctors may be too busy to look through ophthalmoscope. So this is one important role for nurses. Next. Patients also can be part of the management team in the long run. They can do self-care, they can be peer educators, they can be policy advocates. Next. So we work all over Ethiopia, as Simon mentioned, and this is the purpose, is to create models of primary care. We link 15 primary hospitals with 45 health centers. Each hospital is as a satellite of 3 health centers. So the cascading of training, mentoring, and everything is done. And this model can be replicated later on, hopefully, to the rest of the primary health care. Health centers alone are about 3,000. So this is just a drop in the rain. Next. There are a lot of challenges, health worker, but these challenges, of course, are opportunities to learn rather than a reason for frustration. Health workforce, monitoring and evaluation, learning, community engagement, quality of care, and system integration, which can be improved and would be a motivating force to the health workforce. Next. First, staff turnover is an important problem. On all levels, staff, after being trained, they move on. So this is, retention is one of a big issue, retaining health staff at the rural point, at the primary care. So there are a lot of recommendations, but to mention few, the staff rotation traditions has to change, pre-service curricular revision, making probably nurses prescribers as they come out, community nurses. Mentorship and ongoing support is also motivating factors that might keep staff longer. Next. Monitoring and evaluation and learning is important. As I've already mentioned, some people argue that taking complex care to primary health level may affect quality, while ourselves and our partners, we think that, by giving access to rural patients and by relieving burden to hospitals and a few specialists, we actually improve services, but this needs to be supported by evidence, whichever way. So poor recording is there for various reasons, because the health primary care workers complain of workload, additional work for the same wage. But we also believe there is another problem of ownership. If indicators are not reportable at the national level, then the staff is less motivated to really take it as their job. And the other thing is recognition and rewarding of staff is very important, because if you give more job but the same wage, then you have to say thank you at least. Digital health could be helpful to decrease the workload. Next slide, please. Community engagement is very important area. Here also, there is a lot of challenges because the health extension workers or the community health agents have a lot of responsibilities on their lap. So we need to optimize tasks. So all programs, HIV, TB, vaccination, if everybody goes to, health extension workers, then they will be loaded. So how do we optimize? Should we increase their numbers, which is not realistic at the moment because it's resource intensive? Should they specialize is another question. But training, more training, appropriate technology like on digital technology, supplies of equipment for screening are important. Next. Quality also, we cannot say is perfect, but a lot of challenges in that area also, but a lot of things can be done to keep the quality. The referral and linkage between primary and hospitals and health centers and tertiary hospitals still is a problem that has to be strengthened to maintain quality. Nurses has to be trained more in behavioral change communication counseling to achieve some of the poor adherence and high loss to follow-ups, regular tracing through community health agents of those who are lost to follow-up. These are areas for improvement. Next. So what we do in a nutshell, in a summary, is, we train the GPs, young physician at the primary hospital. They do their practice and train down up to the community level. The nurses also share that. And this is in a nutshell what we do. Thank you very much.
Thank you very much, Yoseph. Very interesting and a fabulous start to our presentations. So without further ado, I'll hand over to our second speaker, the wonderful Christine Hancock. Over to you, Christine.
Thank you. And I like the wonderful, and hello to the wonderful participants. I'm delighted to be with you today. Next, please. So I founded C3 Collaborating for Health as an organization with a vision for a world where people aren't dying from preventable chronic disease because they find it easier to live healthy lives. Next. So we're a global health charity and bring together different communities to create changes that make it easier for people to improve what they eat and drink, stop smoking, and be more physically active. Those three behaviors increase the risk of 5 major chronic diseases: heart disease and stroke, type 2 diabetes, many cancers, chronic respiratory illness, and dementia. And they lead to over 70% of global deaths. Everybody knows prevention is better than cure. No smoking, more physical activity, and a better diet. Next. And that means we could prevent much of the burden. We could prevent 80% of diabetes, 40% of many cancers, and 80% of cardiovascular disease. Next. In C3, we have 3 areas where we work, but a major one is working with communities, because where you live influences how you live. I'm sure many people on the call are familiar with the social determinants of health. Those of us working in healthcare have a modest contribution to the health of the population. Much is determined by education, economics, locally and nationally, social and community context, and the built environment. So engaging communities who are experts in their own health needs is the best way to break down environmental barriers to living a healthy life and generating sustainable change. We use a tablet-based mapping tool, which is a process which developed from international research. It stands for Community Health Engagement Survey Solutions, a mouthful, CHESS. With using CHESS, community members take an active role in analysing their environment. This enables understanding of whether an area is conducive to good health or not, and equips the community with an argument for change, and facilitates generation of actions and solutions. Next. Project is described by this timeline. We start with desk research. We meet and identify local people in the community and hopefully find someone to be the project lead, the manager. We engage community members and then they survey their area using CHESS, using the mapping tool, collect data, which is then collated and fed back to community members for an insight session where they can consider what action plans would make a difference to where they live. Hopefully, as part of any project, we can find a small amount of grant monies so that when the community decide on some interventions that they believe would make a difference, and they're always so modest in what they want that a small amount of money is available. Next. In addition, a second area where we work is our nursing programme. Dr. Mamo has made it clear how important the nurses are in his own work and programme. There are 28 million nurses in the world. We believe that we need to work with them to improve their own health so they can disseminate knowledge and promote skills development with their colleagues. And then they can advocate for prevention locally, nationally, and internationally. Next. I often quote a long ago Director General of WHO, Dr. Mahler, who almost 40 years ago said, if the millions of nurses in 1,000 different places could articulate the same ideas and convictions and come together as one force, they could act as a powerhouse for change. Next. So working with nurses, we believe that nurses have to care for themselves as well as care for patients. Yes. Next. We a project working in Scotland with 5 experienced community nurses who completed a masterclass in NCD prevention and then translated that knowledge and experience to their own communities by engaging local community partners to conduct chess activities. One of these very experienced primary care nurses said, "This has changed my perspective on how I see things in my own community." And another, who walked in an area where she was born and grew up, said, "Our patients really don't have choices." Next. A third and the final area that I want to raise today is the question of oral health. Last year, WHO released the first ever country oral health profiles for all members, and it was quite shocking. Half the people in the world have some form of oral disease, disproportionately in the global south. An inability to treat oral disease leads to problems with work, with study, and with the growth of children. Next. Oral diseases disproportionately affect the low middle-income countries, with 3 out of 4 people being affected. Many oral diseases have clear links to other non-communicable diseases, diabetes, oral cancers, and cardiovascular disease. So what C3 wants to do is engage the global nursing workforce. We have a strong track record in dialogue with nurses, and we have expertise in NCD prevention. And we're raising awareness, knowledge, and competency among nurses in the context of oral health and disease prevention. There may not be enough nurses in your country, or even mine, but there are many more nurses than dentists and doctors, especially in most low middle income countries. And nurses usually have a closer and unique relationship with patients. WHO states that it is essential oral healthcare is the entry level to the formal healthcare system. Next. So our work at C3 is to raise awareness globally of the need for nurses to address these issues. We've been working for over a year with a global steering group of nurse leaders from 12 countries, from west to east, or east to west. These are not experts on oral health. They're nurses with leadership roles who, inspired by the understanding of oral health, can take the message through to their country. We're also partnering with the Commonwealth Nurses and Midwives Federation and the World Continuing Education Alliance to raise awareness about the importance of oral health and elevate the need for oral health education for nurses and midwives in practice. At the moment, this initiative combines surveying nurses in Kenya, South Africa, and Tanzania, and developing continuing professional development modules on oral health. Next. The Sustainable Development Goals, which are driving and most of our work at the moment, is to reduce by 1/3 premature mortality from NCDs through prevention and treatment, and to promote mental health and well-being. Very few countries will achieve the reduction in premature mortality needed, although there has been progress across key causes of early disease and death. But the considerable progress made before 2010 has dwindled, and for instance, global diabetes trends are worsening. Next. WHO, who've, like most of us, have spent so much of the last 2 years with understandable concern about COVID-19, points out that it's preyed on people with NCDs, such as cancer, cardiovascular disease, diabetes, and respiratory disease. Globally, NCDs and their risk factors are increasing the vulnerability to COVID-19 infection and the likelihood of worse outcomes. The pandemic has underscored the urgency of addressing NCDs and their risk factors. So finally, my question to you: what single action would make most impact in preventing chronic disease in your country? Thank you.
Wonderful, thank you. And I will now hand on to our next speaker. Our third speaker, as introduced previously, is Niclas Forsling. Over to you, Niclas.
Thank you very much. Yes, I work for a center called the Center for Rural Medicine, an R&D unit in northern part of Sweden. Next, please. Here you can see northern part of Sweden. Sweden is a very large country, and our head office is in the very inland of Västerbotten, the county of Västerbotten, the second northernmost county in Sweden. They are around 15 employees spread across the Nordic region. Mainly funded through different type of projects that we collaborate around. And just to explain the conditions that we work in, you see Storuman municipality is a large municipality. We're having approximately 6,000 people living in the municipality, but we're only 0.7 people per square kilometer. If you take the municipality above us, socially, they have less than 0.5 people per square kilometer. So if you round it to the closest digit, it becomes 0 people living there. But still, we provide healthcare services, primary care services, and social care services in this area. So next, please. Since we are quite unique, we still view us to be very much in the center of the world, but we collaborate around the possibilities of developing rural medicine with different type of entities across the world and have a lot of different projects going. Next, please. So I'm going to give you a kind of background of how we are shaping our primary care services in our region, and this is based very much on the work done through the Nordic Council of Ministers and their presidency starting 2018, and we did this together with the Nordic Welfare Center between 2018 to 2021. Next slide, please. You can find all this information on healthcareatdistance.com, which is a kind of knowledge hub where we collected all the information, where you can go back and look at the information that I will share with you now. Please, next. So we're starting, of course, from an aging population, and as you understood from in our part of the world, with so few people living in the area, we have a quite high aging population. Many of the municipalities that we are collaborating with, that we are serving with new knowledge, are having more than 30% of the population being plus 65 years old. This is the trend that is coming across Europe and is estimated to be the average population combination in 2050 for all European countries. So next slide, please. So what we have done is that we have looked into the possibilities of providing primary care a little bit different through distance spending solutions. So what we needed to start with was to look at the existing solutions for distance spending services within primary care. So we mapped out all of these different services that are existing in the Nordics, several hundreds, and made a publication called 24 Practical Examples of healthcare care through distance spending solutions. And we thought that that's actually a bestseller, this publication. It's a very appreciated publication, and it was translated into English in 2020, just before the pandemics, and then it took off. So we started to think, if solutions are existing in the real world. Why isn't this really being rolled out? So we looked into how to implement these solutions, and we have found a guideline called Roadmap for Service Innovation, which is based on implementation research. And this Roadmap for Service implementation are connected with a number of tools and demonstrates well how to implement different type of services. And the focus needs to be to make it work in primary care very much on insight and anchoring, to understand why are we doing this and who are we doing this for, and get the entire professional core with you in this work. So when we had identified that roadmap for service roadmap for service implementation, then we started to see what can we actually test this one. So we implemented distance learning solutions for healthcare, mainly primary care, in 52 together with 8 healthcare regions of 52 municipalities. So it was very much integrated healthcare and care services. And then we started to think, if this works, maybe it affects how people that are working within these conditions. What do they think about this? So next slide, please. And then next slide again, please. And then we looked into a made a report called "It's All About the People," and we did this based on 15 interviews on different type of professionals within primary care and some within social care, to understand how is it to work within the conditions where a lot of the services are provided with distance learning solutions. So next slide, please. It turned out that the professionals working with these type of solutions to connect with the population, they find the work to become easier and more flexible. They have more time to focus on what is important. So the cases that they meet physically with physical attention are the most important ones, and they are getting to use their trained knowledge to a great extent. And this is very appreciated also according to the readers that we interviewed by the citizens. So it gives a greater meaning to the job. And the people that are working, the people that are managers of these institutions, they normally say that this increased the status of the jobs. So next slide, please. So if we know that the professionals like this, then we thought maybe it has a climate impact. What the climate impact is related to this. So next slide, please. And next slide again. So we let Stockholm Environment Institute to look into this for us, and we have a service within that we have developed called Community Health Rooms. Initially it was named Virtual Health Rooms, where we provide services from rooms that people can go into and do different type of measurements and different type of tests, and provide very much self-monitoring and self-care services from. But there are no professionals working these rooms, so it's up for the citizens themselves to conduct their healthcare services in these rooms. And we made a calculation, and it turned out by the calculations from Stockholm Environment Institute that if we would transfer service provision to more distance learning service provision, we would of course increase or decrease the amount of traveling for the people that are living in these type of very rural areas. But we would also change the way healthcare services on primary level is organized. We wouldn't have to have that much, housing infrastructure, since many of the services could be provided from homes. And those two factors have a very positive environmental impact. So next slide, please. Then we thought, maybe what are the users' experience from this type of services? So next slide, please. And next again. So we made a kind of very brief scoping review. From a few hundred articles, we picked out 40 that we reviewed with a closer scope, and we asked ourselves, what do the users feel about distance learning solutions in healthcare and care? And it turned out that the users of these services, they are very, very positive. So, but we should say that it's very small studies. The studies are not, it's not that many people that have been involved in these service provision. Not that many citizens that have been involved, meaning that there could also be a kind of level of bias in this, that they have been voluntarily taken on, voluntarily assigned to be part of this type of development. So it's very much a field that needs more attention and more research to understand what the citizens' experience are from this. And this is just the citizen experience, not looking into the quality of the services and the possible health effects of this. So, but in general, very positive experience from users. So next slide, please. So then we thought, maybe, how does this have when it comes to contribution to regional development? If you take the next slide and next again. Then we had an institution, a Nordic institution called Nordregio, a spatial planning institute, looking into this to see, is distance planning solutions for healthcare and care through mainly within primary care then, as our field of focus is. Could this be a kind of road to walk if you want regional development to occur in different regions? And they see this at all different sustainability parameters, economic, social, and environmental, that developing distance planning solutions, healthcare and primary care is a way forward. So this is very much recommended if you have an area that are being that are going through regional development, maybe investments are coming to a region, to consider to scale up service provision with distance planning solutions. So next slide, please. So this is coming to the end of my presentation, and my main question to you is, if we know that the citizens like this, there are services out there that are possible to implement and that we know can be implemented, and we know that it has a positive environmental impact, and we know that the citizens like this, why doesn't this happen? Why doesn't this being rolled out widely to communities across the world, and in our case, mainly to communities in the Nordics? Thank you very much.
Thank you, Niclas. So we move on now to our fourth speaker, someone I've known and worked with for many years, Professor Niro Siriwardena. Over to you, Niro. Thank you.
Thank you so much, Simon. Can you hear me okay? Yeah, brilliant. So thank you so much for the introduction, and thank you for allowing me to speak in this meeting. I'm going to speak about a specific area around the primary care workforce, and that's about ensuring a diverse primary care medical workforce. I think diversity is important, and I'll explain why as I go through this. And I think it's relevant for many countries, particularly as we're thinking about the populations that we serve. So next slide. I lead a research centre at Lincoln. Lincoln's in the East Midlands of the UK and England. It's a large rural area, and the Community and Health Research Unit, which I lead, I'm very proud that it's a very diverse group of researchers who I work with. So in the next slide, you'll see what I'm going to talk about, which is a little bit of background to why a diverse workforce in primary care is very important. That it's not just doctors, but also other professionals working in primary care. I'm going to talk about a problem that we've been facing in the UK, which is, we term it differential attainment. So the problem of different groups of doctors having greater difficulty in attaining licensing in the UK. And I'll say a little bit about what our research tells us that this might be due to, and then something about potential solutions. So next slide. This report from the General Medical Council, which was published last year, the State of Medical Education and Practice in the UK, the Workforce Report. In the introduction, they say this very important statement: if we do not take tangible action to make support, inclusivity and fairness the norm, we will be doing a disservice not only to the doctors who want to work here, but also patients in need of their care. And I think this is really important. We're serving as primary care practitioners, and I'm a GP by background, a very diverse population, diverse in terms of population spread, rurality, urban, socioeconomic deprivation, disability, ethnicity, and so on, and particularly with populations that are moving across countries, and more of that is happening. We need to have a diverse workforce to serve our population. So in the next slide, you'll see something about the demographic changes that have been happening in the medical workforce in the UK. So this is the female-male spread. You can see that more women are entering the GP workforce than men, and that's increasing over time. In the next slide, you'll see in terms of ethnicity, there's an increasing ethnic spread of doctors entering the primary care workforce. And then in the next slide, you'll see that international medical graduates are increasing in the proportion of doctors entering the primary care workforce. So you can see here the split in terms of international medical graduates, or IMG, doctors from the European Economic Area and doctors trained in the UK. I mean, part of the problem here, of course, is that we may not be training enough doctors in the UK, and that is increasing, but you can see that there are many doctors entering the primary care workforce who are international medical graduates. Now, in the next slide, the other thing to consider is doctors with disabilities. And in this survey, around 4% of doctors declared one or more disabilities. That's compared to around 20% of the population. And interestingly, the commonest disability amongst doctors is specific learning difficulty. I don't know if that's an issue for you in the health systems that you're working in, but in general practice, it's over 10%, possibly even up to 20% of the doctors entering general practice have a specific learning difficulty of one sort or another. So in the next slide, you'll see a little bit about this issue of differential attainment. By this, I mean differences in performance for doctors trying to get their license to practice as GPs after training, and differences by protected characteristics such as sex, ethnicity, or disability. For us here in the UK, this is a really important issue. It's been very controversial, and there are many ethical and legal issues around fairness for doctors going through training and then getting their license to practice. And this came to a head around about 10 years ago, when the General Medical Council and the Royal Court of GPs were taken to a judicial review to look at fairness in their assessments. There are no clear explanations of why this problem of differential attainment exists, but there are lots of theories, and we've been looking at what might be underlying this. So if we go to the next slide, I think this quote from Mencken says a lot about the difficulty of answering this complex problem around differential attainment. There are often answers promoted, But if you click again, you'll see that for every simple answer, they're often wrong. And so we need to look at this in much more detail, and we've started to do that. So in the next slide, we can start to consider factors contributing to performance. So here we got the problem of differential attainment. And if you click through these and keep clicking, you can look at the assessment method, the examiner, the candidate, education and training, equipment, or environment that all may contribute to performance of doctors through their training. Then if we look at the next slide, this summarizes some of the trainee and educational factors that might be at play. So in trainees, there may be their personal attributes such as culture, ethnicity, race, sex, gender, age, specific learning difficulties, their educational experience, and that may be through school or undergraduate training, in medicine through postgraduate training. We know that there's much inexperience with the NHS and assessment methods, for example, from international medical graduates. There may be psychological factors such as motivation, insight, expectations. So you know, individuals' expectations of what they can and will achieve, and also their trainers, people's confidence, their perception of bias. And in terms of social factors, relationships with educators, relationships with peers, other social factors affecting people's ability to train and to work. And that was summarized in Kath Wolf's work around fair training pathways. In the next slide, we also look at assessment factors. So one of the things that's been put forward in the UK is that the problem here around fairness is around the assessment. You know, is there bias in how the assessment's done through the examiners, through unconscious bias? What about role players in clinical skills assessment? You know, are they biased? What about the cases or the items in the questions? And what about psychometric factors in terms of standard setting? So in the next slide, I'm going to talk about a study that we've just completed and is published in the British Journal of General Practitioners. And we looked at the performance of different candidate groups, and we looked at around 3,500 doctors from when they'd taken their test to be selected into general practice training. That's called the multi-specialty recruitment assessment. And looked at then their performance in workplace-based assessment through an annual review of competence progression in an applied knowledge test, which is a computer-based test of applied knowledge, a clinical skills assessment, or recorded consultation assessment, which are tests of clinical skills. And if you look through the next set of slides, so the first one is looking at factors associated with passing the applied knowledge test. There are a lot of numbers here, but I've summarized the most important and highlighted the most important, I should say. And what you can see here is we looked at different predictors of performance in the applied knowledge test, which is one of the licensing tests for general practice in the UK, and looked at these different predictors: sex, ethnicity, country of qualification, disability. The MSRA, the multi-specialty recruitment assessment, is the selection test, and looked in this multivariate model about what are the important factors determining performance. And you can see that ethnic minority doctors are significantly different from white British doctors in their ability to pass the applied knowledge test once you take everything else into account. And in fact, they're more likely to pass compared to white British doctors. If you look at the next slide, you can see in the clinical skills assessment that ethnic minority doctors are no less likely to pass, but doctors from trained overseas are less likely to pass, and those with declared disabilities. And then if you look at the next slide, you'll see in the recorded consultation assessment, again, overseas trained doctors are less likely to pass this assessment, but not so minority ethnic doctors. And then if you look at the final slide in this series, when we looked at annual progression through training and the workplace-based assessment and whether doctors could progress from 1 year to the next in their 3-year training program, you can see the factors that are most important. So male sex, minority ethnic status, not so important, but country of qualification and disability do affect ability to progress through training. So the next slide sort of shows what I've concluded through these studies and through other studies that we've done, that there are causes of differential attainment which are amenable to intervention. And one of the areas that is highlighted here is selection scores. These scores, MSRA scores at selection into general practice, are the key predictor of how people do subsequently. But learning disabilities and learning difficulties like dyslexia are very important, and provision of education, support, reasonable adjustments are very important. And education and training, particularly of those doctors who do less well at selection and international medical graduates, is really important. I think there are lots of areas where evidence is lacking. There's no very good evidence for bias in assessment, or that relationships with educators or peers make a difference, or expectation and insight. And we know that there's a lot of variation in different training programs and outcomes, and people are starting to look at different educational interventions and how this can affect performance of the different groups that we've described. So I'm going to end with a question. So on the last slide, thank you so much for listening, but how do you ensure diversity in your primary care workforce? And it's something that we've been thinking about and starting to get some understanding of. So thank you very much indeed.
Thank you, Niro. And I see that the questions from each speaker have been posted into the chat as people are talking, and I will take us through each of those in turn in a while. I just wanted to pick up something I had seen in the chat. I'm working with Niro in this area and know that the term learning difficulty is something that the General Medical Council currently use for the data, which means it's the data that Niro has to work with. Many nationally and internationally now use the more modern term of neurodiversity. This is not suggesting that doctors in general practice or indeed anywhere else have high rates of learning disability. It is another aspect of this fabulous diversity that we bring to our workforce. So I just want to make sure that wasn't a challenge for us as we move into the discussions. So now that we have heard from Niro, we move on to our last but no means least presenter, Dr. Katherine Rouleau, who, as I said at the start, has not able to join us now and therefore has sent us a recording of her presentation. And I will hand over to the team to play that recording. Thank you very much.
Hello, my name is Katherine Rouleau. I'm a family physician in Toronto, Canada, and I want to thank the organizers for inviting me to present today on the primary healthcare workforce in the Canadian context. I'm sorry that I couldn't be with you live today. I will try to advance my slides. For some reason, I've had a bit of difficulty technically, but here we go. As we customarily do here in Toronto, I want to begin by acknowledging that the land from which I'm presenting today is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. I'm grateful for the opportunity to work, live, and learn on this land, and I'm committed to working purposely towards reconciliation with Indigenous peoples. Now, if we turn to the objectives for the day, I want to highlight them here. I will first describe the relationship between primary health care and primary care. I'm going to describe an example of an Ontario family health team, the one to which I belong, and then I'll reflect on 5 primary care workforce issues at play in the current Canadian context and the related lessons. So first, for the conceptual clarification of primary health care and primary care. Some of you may assume that they mean the same thing, but in fact, in the context of the WHO, they mean slightly different things. Primary health care is a whole-of-society approach to effectively organize and strengthen national health systems to bring services for health and well-being closer to communities. On the other hand, primary care has to do with service delivery, and specifically the part of the health system that delivers essential health and social services to address the majority of people's health needs close to where they live and work. Again, in the context of the WHO, high-quality primary care is delivered through models of care that produce comprehensive, continuous, coordinated first contact access and person-centered care, which are also community-based and population-informed. This is a visual representation of primary health care, which you can find in the Vision for Primary Healthcare in the 21st Century document published by the WHO in 2018. You see from this diagram that primary healthcare includes the 3 inseparable components of multi-sectorial policy and action, empowered people and communities, and integrated health services with an emphasis on primary care and essential public health functions. And here you see the relationship between primary care and primary health care. I presented this today because while I was invited to present on the primary healthcare workforce, I will focus this presentation on what I know best, which is the primary care workforce. And that's the workforce to which I belong here in Canada. And so moving now to the second part of my presentation, I want to describe briefly to you my family health team. And I do this to situate my later comments in my own reality, to give you an idea of where I sit, where I stand, and where I get my perspective on the Canadian health workforce. I should specify that in Canada, healthcare is organized and funded and delivered through the provinces. I say funded, which is not entirely true. In fact, the funding comes from the federal government and flows to the provinces, but certainly how the funding is allocated and how services are organized is the remit of the provinces. And so in actual fact, in Canada, we have several health systems. We have 10 provinces and 3 territories, and we have as many health systems as that. Now, in Toronto, where I live, I belong to a family health team, which in fact spans 6 clinical sites located within approximately a 7-kilometer radius. Our family health team is part of and affiliated with St. Michael's Hospital. And our patient population, while incredibly diverse and spanning the full representation of the Canadian population, is skewed towards the lower 2 income quintiles with a higher, excuse me, of course I was going to sneeze during the presentation, with a higher proportion of patients contending with adverse social determinants of health, particularly poverty. So in my family health team, each clinic or site, I think you call them surgeries in England or in the UK. Each of these sites is organized slightly differently, but we do use a common electronic health record across the 6 clinics. And that electronic health record, importantly, is separate and different from the one used inside the hospital, largely to reflect the fact that the work we do is very different. Our patients are actually rostered or registered and paneled to a single doctor, but when we deliver urgent care or do after-hour clinics, we cover all of the patients of our family health teams. Most nurses are assigned to one specific clinical site, like the doctors, but other professionals, because of their numbers, may cover 2 separate clinics or even sometimes 3, and I'll come back to that. The doctors in our system are actually private providers. We are not employees of the ministry nor employees of the hospital, although we have we are granted privileges by the hospital, but we are paid essentially as small businesses through the public funds that are flown from taxes to the federal government, to the province, and then to the doctors. We are paid through a capitation payment, and this is a new thing, a relatively new thing for us. Earlier in my career, I was actually remunerated through a fee-for-service method, but now as a family health team, we are remunerated through a blended capitation payment, where we are given an annual amount of funding for each patient based on sex and age. Unfortunately, to date, there are no modifiers to account for complexity of patients. We understand that this may be coming in the Ontario system soon. In addition to that, I get what we call the preventative care bonus, which essentially is a additional amount of money that is proportional to how successful and assiduous I am at delivering the prescribed preventative care measures as dictated by the clinical guidelines, and those include childhood immunization and cancer screening, for example. We also get a small portion of our fee-for-service billings. All the other staff on the teams, however, are paid through salaries by the hospital, and all of us report in terms of governance to the Department of the Family and Community Medicine Department at St. Michael's Hospital. And so the base team includes nurses, nurse practitioners, pharmacists, dietitians, social workers, and trainees. We're very fortunate, actually, to have such well equipped and such rich teams. There are a few other services which I've mentioned before are shared between the 6 clinics, and I want to bring to your attention here the Income Security Health Promoter, which is a fairly unique position in the Ontario context, and is a role where a particular person on the team is responsible for meeting with patients who are living in poverty, to make sure that they have optimized their access to the various support funding programs that are offered by the governments, and to optimize their budgets. As you can see, there's a whole host of members of the team, of roles and scopes of practice. We also have some of our family physicians who have enhanced skills or additional skills in some areas like low-risk obstetrics, addiction medicine, palliative care, care of the elderly, and these individuals serve as resources for all those of us who deliver comprehensive family medicine. And in addition, we have a few specialists who are co-located and run clinics essentially on site a few times a week, and deliver care in a shared care models, and those include pediatricians and psychiatrists. And so our care, the care we deliver is comprehensive primary care. We also have a fairly high proportion of complex care in our population, both because of the population we serve and because of the epidemiology of the Canadian population. And I wanted to highlight the fact, because I'll say a thing or two about teams later, that our approach is very deeply relational, and that's an important thing, you know, as I'll discuss in a moment, around the issues that we are faced with in terms of the health workforce in the Canadian context. And also to prepare the next section, where I will address 5 specific issues, I want to highlight here some of the lessons that we've learned as a family health team over the last year, as we have moved actually physically from one clinic to another. And we've moved to a much larger space, to a somewhat larger space, but that is organized very differently. And we've noticed actually that the changing of the space and the changed distribution, where we sit in that space, has actually changed the way we relate to each other and talk to each other. Of course, there was COVID in the middle of all this, and this has not undoubtedly affected the way we relate. But I've been struck myself actually about the impact of space on the ability to collaborate and come together as a team. We've also expanded in size, and that too has actually generated quite a reflection in us, and there seems to be a sweet spot in terms of the size of a team and the optimal function of a team, where if it gets too large, it becomes difficult to really play together in unison and to really remain aware of the needs and the inputs of the various members of the team. And lastly, we do use a common electronic medical record, and we've noticed that this has enabled communication in many ways, but it has also created some barriers and others. And this is important, again, to keep in mind as we move forward in our Canadian context in trying to enhance access to primary care by shifting to expanding the family health team model.
Thank you very much for that recording. We did stop the recording slightly early to try and keep to time, and apologies for that. And you can now see Dr. Katherine Rouleau's question there. So if I could ask my fellow panelists to come back onto camera. I have 5 questions that have been posed by our speakers. We will go through each of those 5 briefly, probably about 4 or 5 minutes for each of them. So it's going to need to be quite quick responses from my fellow panelists. And then there's a fabulous team that have been going through all the questions that you've posted and have put them onto another document. I'm so used to working across multiple screens, and today I'm on one laptop, which is meaning that it's a very small font and I have reached a certain age, so it's going to be fun. But we'll try and cover as many of your questions in the second half as well. Just to reassure people, whichever time zone you're in, it's currently 7 minutes past the hour. We will finish promptly on or just before the hour. So you can plan whatever it is you're doing next, even if that is sleeping. So our first question was from Dr. Yoseph Mamo, and I have to say it was fabulous that we've been across continents and across global north and south, and that truly reflects the diversity that the WHO wanted as well. And if I just remind people, Dr. Mamo's question was, is the primary care approach for non-communicable disease prevention and control affecting quality in a negative way, or does it enhance it? What do you think, and why? And he asked for a sort of reason. So I'm going to ask each of you in turn whether a primary care approach is negative or positive for non-communicable diseases. It feels appropriate, not least as having recently read Invisible Women. I know that men talk first and over far too much, and as father of daughters, I'm not going to let that happen. But also what I heard from both our first 2 speakers was the importance of nursing and of community engagement. And you both spoke about Africa. So Christine, hopefully you've picked up the hint that I was coming to you first. I'd be interested in your answer to Yoseph. I'm going to use first names from now on, because I've also noticed that often we end up using titles for men and first names for women, and I'm not prepared to go along with that convention. So I hope you'll all forgive me. I'm going to use first names only from now on. Christine, what do you think?
So before I answer that, you gave me a very nice plug on Invisible Women, and C3 has an international seminar towards the end of this month. I'll put the details in the chat, looking at gender issues in diet and NCDs. And the author of Invisible Women has joined as a participant. So that's a very nice, somewhat convoluted plug. Can you repeat the question for me? Having wandered
I certainly can, and that's entirely my fault. I thought I was giving you time to think, and all I was doing was rambling. I apologize. Is a primary care approach to non-communicable disease prevention and control affecting quality in either a negative or a positive way, and why?
I suppose the answer is, what would be the alternative? And there's no doubt, in my view, that NCDs need tackling at, if you like, both ends. There are some enormous issues that governments or WHO need to address. And if we think of trying to challenge the tobacco companies, for instance. This isn't something that can be left to a rural community. But in terms of thinking about people's behavior, their ability to change what's possible locally, and also their need, I think, to engage with the reality of where they live, their relationships, their understanding of key issues, then local, which is what primary care is. Local is key. The other key thing in primary care, I think, is you never hear anybody talk primary care without talking about the team approach. And you won't be surprised to know that waiting to follow him, I was delighted by Dr. Mamo's approach and his emphasis on nursing. And his example was a very nice one. And I think most of us could replicate that sort of example where a skilled nurse who's there at the right time can spot something really important and make a difference to patient outcomes.
Thank you, that's great. Niclas, I wonder if I might ask you if you have any thoughts on this.
Well, first, I think Christina did it well, so I'm fully agreeing with what she's saying. But I mean, I'm coming from a perspective where we study the possibilities of empowering the citizens by allowing them to have distance learning solutions for healthcare and care. And of course, in such a case, there are possibilities of self-monitoring and self-care that you could actually identify at an early stage some of these diseases. And what we know from a Nordic perspective is that the citizens are very eager and keen on not becoming a burden on any societal services. So they would really like to be able to be empowered to take care of themselves as much as possible. So, but the question was related to primary care, and I fully agree with Christina's answer there. Where should it else be seated than in primary care? And this is where the proximity comes. You know, that you are close to the citizens are so important when it comes to these questions, at least from a Nordic perspective.
Thank you. Niro, any further thoughts before I will then come to you, Yoseph, to see if there's anything you want to add, but I'm going to keep us going through the questions. So Niro, any thoughts from you?
One thing to add, and one of the things that I found as a GP, which I think was an error, was that we at one point in the 1990s, we started to set up clinics for different conditions. Without actually realizing that actually in primary care, there's a huge overlap between different non-communicable diseases. There's a lot of comorbidity in terms of the cardiovascular conditions, you know, and diabetes and so on, hypertension, heart disease, diabetes, and so on. There are links between all of these. And so one of the great things about general practice and the general practice team is that rather than dealing with things separately, you can deal with things together and treat people in a holistic way. It's much more efficient. So I mean, I think primary care is a key place for these issues to be addressed.
Thank you very much. Yoseph, did you have anything you wanted to come back on your question before I move on to Christine's question? You are on mute, unfortunately.
Oh, sorry.
No
well,
worries.
my answer is quite clear on which side I am. So I don't have to take more time, but just to remind, you know, in developing countries, most of the NCDs are, you know, even in developed countries, they are asymptomatic and patients come quite late with complication. And this is a big problem. A big problem, it's expensive. They clog the hospitals, burden the hospitals. But when you have the primary care there, they can easily show up. Better to go to a health center nearby than travel hundreds of kilometers to a hospital just to screen. So as you have seen in this case, it was an incidental finding. Even if we are, even with incidental finding, we can save millions and decrease the burden on healthcare. So I believe it is helpful. It enhances care. But important thing is we have to see the whole system. The cohesion between primary and secondary and tertiary care has to be strong. They have to work together. They cannot work independently. There should be strong link, and the tertiary centers have to utilize and use these primary cares as outreach more, and train, support, motivate that more of our communities get the help. That is all I can
Thank
say.
you. Thank you, Yoseph. Leave your microphone on, because I'm going to come to you first on the next question, because I think your answer will just flow from that one. So the next question was from Christine. It's, what single action would make the most impact in preventing chronic non-communicable diseases in your country? So what single action would make the most impact? Yoseph, I realize you're already in full flow on this topic, but I wonder if you have any further thoughts.
Yeah, with regard to chronic disease, as I said, the most important, the big pool of patients we have not reached, because most of them are asymptomatic in early stage. So a lot of awareness creation is very important. A lot of awareness, a lot of promotion of healthy lifestyle is very important. And of course, this has its consequences. It's going to overwhelm the health system, and the health system has to be ready for that. So before you create demand, of course, you have to ready your primary care setup, at least, to screen and do the first line care. So what I believe is, I think awareness raising, working at the primary level, awareness raising, health education to the public, lifestyle changes, and preparing the primary care to take in the flow as it comes, and pass it on to the upper level.
Great.
There are several.
Apologies, didn't mean to talk over you, but thank you. Niro, any thoughts from you?
Apologies, I was muted. Yeah, I agree with what's been said in terms of chronic disease management. I've got to say, I agree with everything Yoseph said, the importance of linking primary, secondary care, thinking about things from a system point of view, thinking about health promotion, prevention, chronic disease management, and linking things up together, I think is really vitally important. So yeah, I really enjoyed the talks covering those areas. Simon, are you?
Thank you, Niclas. Anything you wish to add?
Yeah, maybe I'm becoming a little bit controversial here, but I think at the same time, if you think about how you would like this to be done for you, I think you would, as mentioned, you would like to be informed as soon as possible at the right time, so you can avoid any kind of behavior that are causing these diseases. And maybe it could be, at least this is very much discussed within the Nordics, maybe it's possible for providing access to citizens' health data, so they can generate insights on the basis of their health data, but also other type of data, such as activity data and other actions that you are taking as a citizen and as an individual that are influencing your current well-being. And I would like to see if that could actually, lead people to a direction to motivate them to stay on the path that are more in line to keep yourself out of these different type of chronic conditions.
Thank you. Christine, anything to add on your own question?
So to some extent, it was a trick question, in that, in my view, there is no single thing that you can do to prevent NCDs. It's more, and by implication, I think my fellow panelists have said that, it's complex, it's complicated. It needs lots of things to happen at once, with possibly the one thing, depending on in some countries, and fewer, but still some, I would say, if tobacco isn't a major issue for controlling smoking, then that is almost the most significant thing, because it is still the major, and in some countries way above the major contributor. And I think over recent times in the NCD world, we've moved, probably rightly in some ways, to a concern about food particularly. And in some countries, I think we've taken our eye off tobacco, but that may come up in the conversations.
It may indeed. Thank you. Now, I'm going to slightly change tack as we go into our further questions, because I'm conscious that there's such a rich vein of question and comment coming in the Q&A from our participants across the globe. So what I'm going to do with each of these remaining 3 questions is ask the question and then ask my fellow panelists if they might do something terribly old-fashioned and pre-COVID and actually physically raise their hand so that I can see they're interested in answering. And I'll take 1 or 2 on each question, just to keep us flowing into our audience questions, because I think it would be disrespectful of them if we just filled the whole time of us. As much as I'm enjoying the conversation, I hope you'll forgive me and work with me on that. So our third question is from Niclas. It's what do you think is needed to get healthcare services through distance spanning solutions to be widely used and accepted in your regions? Any of my fellow panelists want to raise a hand and help with the distance and rural question? And of course, also Niclas was covering climate impact in that as well. This may have backfired on me already with no hands going up. Thank you, Niro. Go for it. I owe you.
Yeah, so I think this is a really difficult one. I think I liked your talk, Niclas, because it talked about the technologies that are available and how they can be used. But I think it remains, I think COVID has changed things, hasn't it? That we're using remote technologies much more now for consulting, etc. There's been a huge vogue around remote monitoring, for example, and the idea that remote monitoring might do something in terms of early detection and so on. But I think it's been very, very problematic because there hasn't been enough capacity in the system for people to check things, to figure out what to do when abnormal measures come in through remote monitoring. There isn't enough linkage between the various parts of the system to do that. So I think there are lots of problems that we need to think about solutions to for this to be effective. But I agree with you. I think it has huge potential. That's my starter for 10, Simon.
Great, thank you. I hope Niclas won't feel too shortchanged, because I'm sure things will come up in the other conversations, and how generously you put your thumb up, I appreciate it. There are quite a few questions that I think I might be coming back to in the audience questions. So again, I'm going to go with 1 or 2 hands on this. But Niro's question to the panel was, how do you ensure diversity in your primary care workforce? Do I have any hands to follow up on that one? Thank you, Christine. Over to you.
Yeah, really interesting presentation, Niro, in terms of the issues. I think, and I'm sure that you do, and that it's the biggest challenge is securing the commitment of everybody else. You can't impose it. And that's and it's making sure you've got yourself past lip service or checklists into a real understanding and belief in its value. And I think that's the thing that challenges all of us, because the question, I think, arises for all of us.
Great, thank you. So Catherine's question, which was put up on the screen after her presentation, was, if you had all the resources in the world to invest in one change to enable the workforce to better deliver, optimally performing primary care, what would that change be and why? We could probably take a couple on this if people have got anything that they would like to put in. What one change would you do for optimally performing primary care? Christine.
I'd ask the workforce what was their priority, because I think people are often very modest, but they really know the things that are blocking them for doing things better. And while you wouldn't need all the resources in the world, you need enough resources to make people feel comfortable to have that conversation, I think.
Thank you. I thought there was something in actually that answered this question in your talk, Yoseph, if I may, which was you talked of the importance of community engagement. And I wonder that often whether we do things to communities rather than with.
It is true. It is true. But as I've already mentioned, the communities in Africa are rural, and most of us are very reluctant to go down there. But I think that is a very important area because, as I said, the area of awareness and lifestyle changes, addresses, the lion's share of the problem. And I think it's a very important area. But I agree completely with Christine about the health workforce, on the front line at the community level, as well as a primary care. They really know the daily challenges and how they can be helped and supported. And I think listening to them would be, a priority.
Thank you. So I'm now going to open the floor to questions from our audience. These are questions that have been posted in the Q&A, and the excellent team behind this webinar have been putting those into a Word document for me. I'm very conscious that, that I've got 12 pages of Word document now, so I apologize if I don't get to your question or the topic that you wanted, but I will do my best to cover some interesting ones. So also I will do my best to pronounce your names correctly, but I'm conscious that normally I would ask you if that's correct. So I hope I don't disrespect anybody with the pronunciation. So firstly, I'm going to come to a question from Fatima Ishrat. What will be the contribution of One Health to make the society less vulnerable for future pandemics when they occur? If I slightly paraphrase that. So we know we're going to get more pandemics. That is inevitable. What will the contribution of One Health be? Who would like to answer that first? I might start picking if we're not careful, and that might feel a bit uncomfortable for people. I don't want to do that if I can help it. Or maybe then if I just slightly reword it and ask each of you, because we've got context from across 3 continents, what's important for what have we learned from this pandemic to help with responding to future pandemics? That will help, because I realize there's jargon in the way we ask questions. So what have we learned that we must not replicate next time there's a pandemic, or get right before the next pandemic? Yoseph, what have you learned in your national and continental context?
Thank you very much. I'm not an expert on infectious diseases, but what I can say in general terms is the global partnership, the global information exchange, must be, the priority. And exchange of information, then everybody will be quite ready for whatever comes. So I put a lot of my money into that. I exchange a global partnership and exchange of information.
Thank you. Niclas, do you have any thoughts on this?
Well, first of all, I agree with Dr. Mamo here, but I think also, I mean, one of I'm coming from the side of studying the distance learning solutions, and of course they played a vital role in being able to performing services during the pandemics. And it's a little bit sad that we see that the use of these type of service provision goes down when we enter a state of normal again, and the learning from this could actually be studied and capture the knowledge how to scale this up, because people are saying that healthcare services are so difficult to transform, but they demonstrated to be world champions in transformation during the pandemics. They did it so well across. So I think that we could actually capture some of that knowledge and learning to be better prepared for the next possible pandemic.
Thank you. Christine, any thoughts?
Yeah, I think one of the things that was so dramatic and so terrible was the vulnerability of frontline healthcare staff, and the slowness, even in rich countries, of protecting those staff. So I think in the UK, something like 250 healthcare staff died at the beginning of the pandemic. And in many countries, that was a much, much higher number. Nurses were particularly vulnerable. And then I suppose, secondly, that given the impact that NCDs had on people's reaction to the virus, then it's not about waiting for the next one so much. It's about addressing those risk factors now as much as we can.
Thank you. Niro, any thoughts?
It's such a complex question and response. I guess you could look at it from many different perspectives. One perspective that we looked at was from the point of view of public health messaging during the pandemic. And I think looking at some of our research in the UK and Canada, one of the things that I would say is consistent, responsive messaging from trustworthy sources, so developing trust in those communicating messages to people, because there was a very much an emphasis on behavior change in the general population, in terms of whether it was mask wearing or lockdowns or vaccination and so on, and these messaging and public health messaging was so critically important to all of that, and trust. So yeah, that's my sort of input.
So great, thank you. And I'm aware actually that I've slipped into a jargon thing here. It was only actually 2 weeks ago at an annual medics and veterinarians dinner at my college in Cambridge that the vets were talking about One Health, and they were horrified that I hadn't heard of it. So I suspect there may be people on this call that hadn't. And it's a WHO initiative, which is fabulous to mention as they're our partners. And I'm reading here that One Health is an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems. And it recognizes that the health of humans, domestic and wild animals, and plants, and the wider environment, including ecosystems, are closely linked and interdependent. So it's not all about humans, folks. It's one health system for the whole world. So thank you very much. We've got a few more questions and a bit of time. I'm going to combine a couple. So Aswani Krishnakumar asks, what are the major ways to strengthen women's empowerment in the future? And Sunny Vishnuhari asks, what are the solutions for a balanced dominance between male and female? So something about gender or sex diversity there, and then I am going to come to the other aspects in a moment. But anybody wish to comment on that? Christine.
So I'm not entirely sure whether the question, clearly the second part is more about professionals, but whether the main question is about population as a whole. But my understanding and belief is, in terms of empowering women in general, it's access to the ability to manage their fertility in a way that they themselves control that is really important. And whether that's controlling horrendous positions where rape is almost permitted in conflict situations, or whether it's about people being able to decide having a small family or indeed no children, and to make the decision themselves. So I think the overwhelmingly, certainly for population-wide, the women's issue is very, very strongly tied up to women being empowered in terms of their own bodies and the children they choose to have or don't have.
Thank you. Very, very powerful and important answer. There was also a question around how can we ensure that people of colour, Black, Asian, and how can we ensure that people of colour are represented in leadership and in management across the globe? Anyone, any thoughts on that, Niro? I think it overlaps with the systemic issues behind differential attainment as well. So, any thoughts? You're on mute, though.
Oops, sorry, I haven't got an answer to leadership globally. What I'm aware of, certainly in the UK, is that more and more leaders in the health service are there's greater diversity in leadership, which is great in terms of role models for doctors moving into those sort of positions. So I think my feeling is that things are changing, but that we can do more to try and encourage people, you know, whichever branch of the health service they're in, whether they're in management or allied health professions or nursing or medicine, to move into those positions and then to try and support them. It's such a complex question, and the solutions, I think, are, as in many of the things that have been raised, are multifactorial in terms of trying to get people into those positions, encourage them, and then support them once they're there.
Thank you. I'm conscious that the first two talks majored on the role of nurses, and I think that therefore is an important thing to cover in the questions as well. And I notice a question from Dr. Marion Lynch about what further evidence or action is needed to convince governments to invest in degree-level nursing numbers at the same time as expanding medical school numbers. My understanding is that the workforce crisis is a global crisis, and that there is no nation, to my knowledge, that has enough. And I will come to that in my next question around brain drain. But on this one, what can be done to ensure that governments value nurses? Christine, I feel that you're going to be itching to come in on that one.
Well, I'd also like to quite take it back to the last question. And this is, I realize, quite controversial, but I think sometimes the issue of the position of women in leadership can conflict with the issue of wanting to be diverse in terms of ethnicity. And I think that's a really challenging area, but I think we need to think about that sometimes those two really important topics, areas, can almost conflict with each other. I have, as you can imagine, and you won't, I hope you'll stop me talking for too long, I have really strong views about how the position of women and the position of nurses is the same. And it's the same at all sorts of levels. And until we really recognise the issue where women are concerned, we probably will have real trouble recognising the challenge of the position of nurses. And I think part of the problem for addressing Marion Lynch's question, is that opinion formers and leaders, still overwhelmingly men, but not entirely, find the intimacy of nursing, the challenge of the reality of work, where you're dealing almost constantly with pain and suffering and stress and distress. Doctors do as well, but they also have a more often intellectual framework that they can talk about. You try going to a party in any country, I guess, and talking in detail about what you did yesterday, if you're a clinical nurse. So Dr. Mamo's example, does that nurse go to a party? She may not have to, and discuss her, what she did in terms of that patient. And yet often a doctor will go and say that they've been operating all day in such and such a way, because they can describe it in a way that's perhaps less embarrassing and intimate. But when you're ill, when you're sick, what you really want is that nurse who does understand that intimacy and that distress and those symptoms that are sometimes worse than the disease itself. But I will stop, Simon.
No, it's a fabulous answer, and I think your linking of the role of or place of women in society, their rights to controlling their own body and their sexual health, and then linking that to nursing is incredibly powerful. Incredibly powerful. Would anybody else like to comment on this topic? Okay. Thank you, Yoseph. Sorry.
I think governments find it obvious and convinced of the nurses' role. But one of the problems in developing countries such as mine is, I think, it goes beyond training. You know, when people are trained further into, from their basic degree into master's degree, they want to move to hospitals or other better jobs. So is it better to train the nurses during their pre-service undergraduate program and equip them more with be a prescribers at that level? Is one issue. Another issue that the most government doesn't want to go into is the financial incentives. So that's also an issue. And nurses, I think, mostly women, need child care services, daycare services, so that they can focus on their work. They also are bound up to patients bedridden at home. So the woman's role, as Christine mentioned, all these factors need commitment to really bring forth this huge potential in our workforce as well as in our community.
Thank you. I feel your answers complement each other brilliantly, and I am struck that although you talk about being from a sort of low middle income country, I don't think there was anything in your answer that doesn't apply to every country with which I've worked. So thank you. So keeping it global, we work within, as I've said, a global health workforce crisis. It's a competitive market. We have the WHO red list, but we certainly have a huge amount of people moving around the world. And the question that's been asked of us here is, how can those in low and middle income countries make their places of work unique and attractive to resist the brain drain? I do wonder also whether the problem isn't actually in those countries, it's the other countries stealing their workforce. So I'm quite happy to broaden that out a little bit. And thank you, Niclas, over to you.
So, we are based in a very remote and rural area. At the same time, we view that as being quite unique and under specific conditions that you have to perform your profession. So for instance, this is just an example of what we are doing within our healthcare region and the universities that we collaborate with for medical education. we have the medical doctors program have been extended 6 months to be able to become a medical doctor with rural skills, and this is very popular. So you could actually brand the difficulties that you see as difficulties as opportunities as well. What we also see is that we have a lot of training, for instance, acute catastrophic medicine in extreme remote areas. So we get doctors to come and train with us from all over Sweden. And this is kind of training that we perform together with them, where they get to know how it is to work within these conditions that are very, very extreme sometimes. And very often from these training, we get a lot of the doctors that are saying that they want to come to work with us for a shorter period of time, sometimes a longer period of time, to learn these type to work within these type of conditions more. So it's not always that you work in a specific area. It's how you view that area. It's normally quite unique, and you need to present a uniqueness from that to be able to become attractive.
Thank you. Anyone else, any thoughts? I'm conscious that Yoseph, you're the only one on this call that is actually based in one of those countries. Christine, you do work very much as well. I don't want you to feel like token pressure on you for that, but I'm conscious that we must be careful not to, if I may put this word in inverted commas, be colonialist in telling people what their solutions are. But Niro.
Yeah, so it seems odd for me to speak because I'm working in England, but just my experience of a scheme that they have in Sri Lanka, where doctors, particularly senior doctors, come over and spend a year with us in the UK. We learn a great deal from them about the Sri Lankan system. And they all go back as senior doctors, and we've had men and women doctors from Sri Lanka, and they go back and they're senior doctors back at in Sri Lanka, and very few, almost none of them have wanted to stay here in the UK as doctors. They've all gone back to their own country. So maybe, some experience of other countries as part of the training might act as a disincentive for people to actually go and work elsewhere. But I mean, there are all sorts of pressures on people, aren't there, to migrate from, as doctors or other health professionals.
Great, thank you. Yoseph or Christine, do you have anything you would like to come in with?
I think, in my opinion, is in the short while, this will not be answered. I mean, it's a natural process of water flowing downstream, and you need a pump to keep it flow upstream. So I think what I think my country is doing is train more nurses and more doctors. That is the only solution. But still, what I think is to address, what motivates, what retains, what attracts them, and what keeps them going should be addressed. It is multifaceted. Financial issues are big ones, but finance alone is not a solution. You have to improve the area of work and make it conducive. That needs leadership. It's an area that is not well considered. We need very good health leaders, transformative leaders, be it physicians, nurses, pharmacists, laboratory technicians, whatever. We need leadership. And I think the satisfaction of helping your community and helping people, not to be overwhelmed too much. Sometimes they burn out. Specialists are overutilized or underutilized. Nurses are exploited or overutilized. These things we have to recognize. And one of the things I mentioned, task sharing, task shifting, division of labor, and supporting each other. linking with mentoring the doctor with the nursing middle level worker. I think we have to consider other issues than finance, but finance are important anyway. And other ways of support, as I've mentioned, in rural areas, staff need a school for their children to stay there longer. Otherwise, they have to move on, and the community will be without support. So it is very complex, but what we can start with at least is, doing with training a lot of health workers. But of course, to train with quality, a lot of workers has its own limitations. You drop in quality when you focus on numbers. But I really don't see there is any way of stopping people migrating. And that is the reality for a while.
Thank you. A very rich answer. I think because you've mentioned leadership, and there was some love for that answer in the chat as well, I'm going to move to our final question because I've got a few bits of housekeeping to wrap up at the end. And there's a question on the adaptivity and agility of teams. And to what extent have you as the panelists seen successful leadership initiatives that support the ability of teams, large and small, to work together across the range of the question says professionals, but I think I would like to broaden that, because I think the primary care team is broader than so-called clinical professionals. So if I could ask those of you, and I will be stopping us promptly in 3 minutes if we're still going, to make sure we finish on time. Any examples of successful team-based leadership initiatives or team-enhancing leadership initiatives?
In my country, I think there is a lot of efforts in producing leaders at the primary care level and at the hospital and tertiary levels. There is interest, there is research ongoing at the moment. So I am very happy, at least it is recognized by the health system. And there are a lot of studies coming up. And I think together with that and other retaining mechanisms, probably part of the solution would soon be available. But there are, I can assure you, there are interests. I am seeing some attention being given to this area.
Great, thank you, Yoseph. Do any of my other panelists want to give any final thoughts? Niro.
Just very briefly, we've done a lot of work on quality improvement and using collaborative approaches to improve healthcare, and found that works very well, particularly if you, and I think just picking up comments from earlier, that you ask people at the front line, what is important, how should we improve, and then provide some techniques, process mapping, statistical process control, feedback, and so on, to then empower and enable frontline health workers to work together in teams. They provide their own leadership, and there's often opinion leadership that you can build on within each of these organizations. And if one plans it and organizes it well, you can then set up small teams with leaders in multiple organizations that can then coordinate through various fora to share ideas, expertise. But I think the overall leadership of those sort of initiatives is very important, so that people are given a voice, supported, given feedback, and encouraged. And I think there are certainly a number of examples, including from us with ambulance services, working around improving heart attack and stroke care, that have shown, very, very significant improvements in care. So that's just an example.
Thank you. So the ticking hand of time is against us. Your panelists, you are off the hook. I would like to, we've reached the end of our seminar today. It's impossible to sum up 5 such fabulous talks and the questions answered, but I did pick out one point from each of our 5 speakers. The importance of primary care for non-communicable diseases, particularly nurses and community engagement. The importance of primary prevention and how much of disease is preventable. And I really picked up on the points around oral health. The distance spanning initiatives that can improve access to healthcare, but also their climate impact. The very real importance of diversity in our primary care workforce. And then the difference between primary health care and primary care service provision. And I feel it's a great credit to our team that we had panelists and presentations from Africa, from Europe, the Nordic countries, and from the North Americas. Over recent years, with the advent of being able to do things over Zoom and Teams, I feel that we are starting to be more inclusive and address the historical global North domination to these events, and I hope have the humility to learn from each other. So I would like to thank our 5 speakers for their presentations, which generated valuable and insightful discussion and debate. I'd like to thank the World Health Organization and our partner countries for sponsoring the programme and the continued relationship with us in Health Education England. When you leave this seminar today, there will be a brief survey in Zoom. If you could please give us your thoughts and feedback, that would be greatly appreciated. We are continually amending the format of our seminars and the content to ensure that we meet your needs, both in terms of content and format. And finally, I'd like to thank all of you for your attendance and your participation. It's been amazing to see so much in the Q&A and to hear of your thoughts as well. As I said at the outset, we will share the recording of this video with all participants, and we'll be advertising our next seminar shortly on the website. Thank you again to the participants, and can I thank the excellent team behind this that have kept this webinar flowing and put the panels together. And again, thank you to you all. Thank you and goodbye.